everyone. Thanks so much for joining. I am Ashley Hudson, National Clinical Liaison with Smith & Nephew. I sure hope you've been enjoying the Wounds Canada conference as much as my team and I have been. Welcome to our sponsored session, A Route to More Effective Chronic Wound Management. Before we get started, there's just a couple of housekeeping questions or tips. Please do post any of the questions that you have for our today's speakers into the Q&A box that you see at the bottom of your screen. I will collate all the questions and we will discuss as many of them as we can at the end of the session. But I do also invite you to pop on over to our Smith & Nephew booth so that you can have a chat or even a video call with myself and our team throughout the weekend. Now, as you're all aware, and probably a lot of the reason why you are at the Wounds Canada conference is that chronic wounds can be challenging to heal. Today, Dr. Kevin Wu and Dr. Carolyn Dowsett will share how you can pave a better path to healing these chronic wounds through utilizing evidence-informed best practice pathways, both for infection management and single-use negative pressure wound therapy. Before we introduce today's excellent speakers, I would like to just take one moment to introduce our Vice President and Managing Director of Smith & Nephew Canada, Dave O'Neill. Thanks so much, Dave, for joining us today.
Thank you, Ashley, and thanks everybody for joining our seminar. Also, just a quick congratulations to Wounds Canada on a fantastic virtual meeting and a terrific programming that they put together. If you can just go back a couple of, yeah, great, thank you. A couple of quick introductions here for two individuals that really don't need any introductions, but I'm honored and privileged to introduce them. Dr. Kevin Wu is an associate professor at Queen's University School of Nursing, School of Rehabilitation Therapy in Kingston, Ontario. He maintains a clinical expertise and functions as an advanced wound consultant at University Health Network in Toronto, as well as West Park Healthcare Centre in Toronto. Dr. Carolyn Dowsett works as a clinical nurse specialist in tissue viability for the East London Foundation Trust, where she is also the clinical lead for the leg ulcer service. Both speakers bring a wealth of clinical expertise, are strong advocates for implementation of best practice pathways, have published numerous journal articles, including A Route to More Effective Infection Management, the Infection Management Pathway, just recently published in September's Wound International Journal. And with that formal introductions of both speakers, I'm going to turn it over to them now and really look forward to an informative and highly insightful program.
Great. Thank you so much, Dave and Ashley, for giving us the introduction. And it's such an honor to be here. I'm watching the number. We have about 200 people participating in this webinar. So it's wonderful to see all of you here. I know the weather is so wonderful outside in Toronto anyway. I'm just looking at the sun through the window. I hope that you're actually walking your dog and enjoying the sun while listening to us delivering this webinar. Anyway, so I want to start with the discussion about chronic wounds. As you know, we don't really have a universally acceptable definition around what is defined or what we call chronic wounds. I think in general, when you look at the literature, people talk about when wounds do not follow a expected pathway of healing, meaning that it's not reducing in size, improving in terms of the quality of wound tissue within 30 days. That's considered as a chronic wound. Maybe that's another project that Caroline and I can work together in the future to provide a better definition around what is chronic wounds. As you're aware, chronic wounds are very common. Globally, about 40 million people have some type of chronic wound problems. The staggering statistics is almost a third of individuals with those wounds, they do not achieve closure within a year. And the problem is they can develop infection, they can develop all kinds of problems, pain, quality of life issues that Caroline is going to talk to us about. So as you can see in this next slide, because of the chronicity of those wounds, the cost is really, really high, especially in Canada. I think Dr. Dowsett can share her insight from the UK perspective. But based on the literature, 1.5 billion are directed to wound surfaces and wound management in Ontario alone, and that's a lot of money.
Well, thank you, Dr. Wu. It's my pleasure to be joining you at Wounds Canada. I'm here from the UK, and really we have a problem with chronic wounds here in the UK, as we all do globally. And we spend up to 5.3 billion in the UK every year treating 2.2 million people who suffer from wounds across our health service. And we know that non-healed wounds result in 135% more patient costs than healed wounds. So where possible, we should always be aiming to heal these wounds. I guess we need to start looking at chronic wounds and this problem from a patient perspective. And you all know from caring for your patients that living with a wound has a significant impact on our patients' quality of life. Patients with chronic wounds report anxiety, frustration, fear and loneliness. And the patients that I see in my leg ulcer clinics will usually report pain, lack of sleep, and sometimes those patients go on to suffer from depression. Wound complications such as infection, and Dr. Wu will talk more into this today, delays wound healing, and that prolongs patient suffering. So if we're really going to optimize patient well-being, we need to prioritize patient-centric discussions in relation to chronic wounds and infection if we are to transform patients' lives. Now, we'd like to start with a polling question. So we'd like to ask you, the audience, what do you define as a hard-to-heal wound? So if you could make your choices, please.
And Dr. Dowsett, I think we did talk about that earlier too, eh?
If you press submit when you've made your choices. Okay. So yes, I guess the thing to say is you're all right. That's wounds that fail to heal. So we've said wounds that have been present for 30 days. We've got non-healable maintenance wounds. So all of these are relevant to chronic non-healing wounds. And what we know is delayed healing is common. Frequently, it's not recognized early enough. It increases patient suffering, your clinical workloads, and of course, cost. So what we need is a more proactive approach to early assessment and intervention. And, you know, the whole purpose of us being here today is to give you some solutions and some tools so that you can recognize these chronic wounds earlier and intervene as appropriate. If we look at the factors that impede wound healing, we look at this from a patient perspective and from a wound perspective, thinking about the systemic factors. So patients' age and their underlying comorbidities. So patients with peripheral arterial disease, patients who suffer from diabetes. We also have to think about people's lifestyle. We know that obesity is on the increase, and things like smoking, alcoholism will also delay wound healing. And then thinking about our patients' immune response, so patients who are immunocompromised, patients who are malnourished, and of course the medications that patients are on. So thinking about steroid therapy or other medications that might impede wound healing. And then if we think about the local wound environment and we think about what might impede wound healing, we have to think about things like oxygenation, how well oxygenated the wound is, infection, thinking about the wound bed and the types of tissue in the wound, and then thinking about foreign bodies, and then other factors such as venous insufficiency that will lead to impeded wound healing if we don't address that underlying problem. So we have another polling question for you now. So I'd like to reach out and ask you, our audience, what are the challenges for you in managing these hard to heal chronic wounds? If you'd like to have a look at the list and make your selection and submit, please. Okay, we have some results here. So you're saying that resources are a concern, as is time, referrals, and that could be that you might not have the appropriate people to refer the patient. Sometimes we refer patients and there's delays in getting them seen, and rightly so, some of you say product selection. So there are many challenges, as you clearly have identified, in managing patients with hard to heal wounds. And I guess we've highlighted those patients' challenges, which we should never really lose sight of. But if I think about it from a healthcare professional and being in clinic and going on home visits to patients, it is time consuming, which you've rightly said. And we know that up to 80% of these patients are managed in the home care setting. And I guess the challenges in that environment is keeping knowledge and skills up to date, so that people are giving the right treatment. And that's why when we talk about evidence-based pathways today, these tools help to promote the right care for the patients. Then we need to think about how we manage those complications, and then we get the right patients referred for advanced therapies and for the right treatment. And then we must be mindful that we work in healthcare systems where we don't have endless budgets. So we have to think about using our resources appropriately. And of course, if we get it wrong and the patient's wound is prolonged, that also increases the cost of care. So over to you now, Dr. Wu, who's going to talk to us about the complication of infection in these challenging wounds.
Great, thank you, Dr. Dowsett. It's great to hear from your perspective some of the challenges. I think it's not so uncommon and very, very similar to what we share in Canada as well. As you mentioned, one of the biggest challenge from my perspective as well in the management of chronic wound is to how to prevent and manage infection as they occur. Based on the literature and consensus papers that you may have seen, they talk about 80% to almost 100% of all chronic wounds have biofilm problem. For people not familiar with the term biofilm, which I think is a buzz term nowadays when we talk about wound management and looking at different dressing ingredients, they all have some degree of anti-biofilm function. And Dr. Dowsett and I would address some of those functions a little bit later based on our discussion in terms of the cases to differentiate when to use silver and when to use iodine-based product, for example. But biofilm is a common problem, and basically it provides this sort of a shield to the bacteria inside the chronic wound environment. And that's why antimicrobial agents and antibodies that our body produce, has a very difficult time to get to the bacteria to kill them and inactivate them. And wound is an ideal environment for bacteria to grow. It's nice and warm, moist, and there's a lot of nutrients, right? So it's the ideal background for infection. And not to mention about the location, many pressure injuries that we see are located in the sacral area, constantly subject to fecal contamination, and not to mention about the cross-contamination that we sometimes see from patient to patients. And that's the reason why chronic wounds become more chronic. And we need to address this problem more judiciously and looking at different interventions. So I want to introduce to you this pathway that Caroline, Dr. Dowsett, myself, and a few other individuals, international experts, developed. And basically integrating a number of key pathways that you've seen in the past. We start with A, B, C, D, E. It's a summary of what we have seen in wound bed preparation paradigm, looking at patient holistically from the individual, from the, and Dr. Dowsett talked about the different systemic local factors that can affect wound healing. So we need to use a very interprofessional, a team approach to look at all the different issues that can affect wound healing. And part of the pathway, this new pathway, not just about wound bed preparation, but we're focusing and shifting our attention to the common signs and symptoms in relation to infection. And Dr. Dowsett and I are actually going to be doing another webinar this week, another advertisement, I guess, and it's going to be on Wednesday, and hopefully you can join us because we'll be talking more about this infection pathway and how to manage local infection and look at the different intervention strategies that we can address biofilm problem. So I want to share with you an interesting case I come across recently and highlight the diversity of wound care strategies that we use to manage this wound. This is a lady, 61-year-old. She came to a rehab facility for rehabilitation. She was just about to be discharged home, and she was rolling around with the electrical wheelchair. Unfortunately, run into the bed frame by mistake, and she developed this big hematoma and swelling problem on her lower leg. And she asked me, "How come I got two phytic on my leg?" I said, "Well, this is not good news. You got this injury, and with the inflammatory response, now you got this collection of fluid and blood. And the worry that I have is patients like this can develop what we call compartment syndrome. With the swelling, the severity of swelling locally, it can compress the circulation, causing ischemic damage to the distal area. And also looking at her past medical history, she's at risk for developing other complications. She is a diabetic patient, also has a history of lymphedema. And that's why, as you can see, the leg is quite swollen already. And in addition to the injury, it's more swollen now. So what we did is send her directly to acute care because we were worried that she's going to lose her leg. And she came back about 10 days after staying in the hospital for duration of time for monitoring, and came back to us to rehab. And this exactly was the picture that I see. And there was nothing much changed. There's still a hematoma. There's a lot of swelling going on. Yes, the area is not as well. The phytics are gone, but now you have this darkened area. So I pick up my scalpel and lance it open and remove as much necrotic tissue, clots, dead material inside the wound as possible. At that time, the measurement of this wound was 20 by 10 centimeters post debridement. And on the next slide, you can see that we continue to use the conventional dressing to change the wound, provide local wound care for a number of days. And the purpose is to try to clean up the clots and try to manage the wound fluid as much as we can. So by day 6, now the wound is slightly bigger, which is kind of expected because we're now cleaning all the necrotic material. The wound measurement was 25 by 17 centimeters. And you can see the picture, there's still a lot of necrotic clots and non-viable tissue on the wound bed, not the healthiest kind of wound bed that you like to see yet. So with the pain, with the increase in the bleeding problem, the patient did not want to have further sharp debridement done. So fortunately, we have central collagenase that is available for us to facilitate enzymatic debridement. So it is an enzyme that we can apply on the wound bed. Usually we apply on a day-to-day basis in terms of that's the half-life that would provide the most effective type of enzymatic debridement. So in 6 days of applying the enzymatic agents on a day-to-day basis, you can see the wound bed has improved significantly. I would say probably there's only around 5% of black, dark necrotic material. Yes, there's still some slough. So we continue to apply the central collagenase on the wound bed to provide better debridement. So on day 14, we come across another issue now. We've been using the enzymatic agent to remove necrotic material. So now the key concern is there's increased drainage, there's increased pain, it's burning, it's really uncomfortable. And we've been using some compression therapy because of the lymphedema. Now she refused to have compression therapy done because of the pain is so severe. And with the increased amount of drainage, there's also increased odor. And we can actually smell the wound from a few doors down in the nursing station. So there's something different, something wrong going on with this picture. So this is a diagram from the pathway illustrating the different signs and symptoms, comparing what we call the biofilm-related infection or covert infection versus overt classic infection signs and symptoms. So as you can see in this picture, think about erythema, increased warmth, increased edema, purulent drainage, pain, the odor. So those are the classic signs of infection. So what did we do? We did something. The next slide. Yeah, we apply Actico based on the pathway that we have created together with Dr. Dowsett. We identify if you're dealing with spreading systemic infection or classic infection, the first line treatment is to use silver material. In this case, a Actico flax material dressing. And Dr. Dowsett will come back to talk to you more about Actico material and how effective it is for the treatment of wound infection. So part of the pathway too is to make sure that we continue with the same treatment for duration of time that we'll come back to talk about. And by day 21, we continue with the Actico for 6 days now. You can see that the wound is slightly changing a little bit. We are concerned now with the friable tissue. There's a little more wound breakdown. The granulation tissue that looked healthier before is now more beefy looking, very easy to break down. And the pain is still very substantial that we need to address. So at this point, we think that we need to think about something different. Based on the pathway, we follow the assessment. And in the next slide, what you can see here is we switch the treatment from the Actico dressing to iodosorb. For people familiar with iodosorb, it is a cadhesomer iodines, basically iodine molecule stored in this starch molecule. In exchange with wound fluid, it releases the iodine into the wound bed and kill bacteria. And there's been some recent literature suggesting the iodine is more effective against biofilm. And in this case, when we see the Actico doesn't seem to be moving the wound forward as much as we like, and with the other signs and symptoms indicating now we're dealing with biofilm problem. And that's why we switch from Actico to iodosorb. And I love the powder because this is a very big, extensive area, high volume of exudate. The powder is definitely more absorbent compared to the ointment and paste that you may be familiar with. And I just sort of sprinkle, I sort of make a joke about because it's come in a satchel of powder, so it's like a shake and bake approach. And you just spread the powder on the wound bed and evenly on the surface. That will allow the agent to interact with the wound tissue and the bacteria. So as you can see, the serial of picture from day 28 to day 38, there's a significant improvement based on the wound characteristics, the wound bed. There's more healthier granulation tissue by day 38. The wound size has gone down from 23.5 by 14 centimeters in size to 21 by 13. And that's a huge improvement. And not to mention about the cleaning up process, removing all the necrotic material and unhealthy granulation tissue. So in the next slide, what you can see here now is day 38. So the question is, well, we achieved so much. What is the next step you would think is the most appropriate treatment? So what will you choose? Continue with enzymatic debridement, antimicrobial dressing, hydrogel, foam dressing, or NPWT, negative pressure wound therapy? Let's see. And the answer is, holy cow, negative pressure wound therapy there, 60%. And that's exactly what I did. So I think great minds think alike. How about that? So by day 43, yes, you can see the wound bed is very healthy looking. And well, what else can we do, right? And this is a big wound. So think about the step up, step down approach to wound management. So we have done everything we could to prepare a healthier wound bed. So the next step, perhaps we need to think about adjunct therapy, advanced therapy to facilitate the edge migration. In this case, we initiated single-use negative pressure wound therapy. And what you see in this picture on day 43 is a PICO 14 dressing, which Dr. Dowsett would be explaining a bit more about what this interesting therapy is about. But before I pass it back on to Caroline, you can see by day 64, using the therapy for 20 days, the significant reduction in the size of the wound from 20 by 12 to 18 by 10 centimeters in size. The wound bed is healthy looking. You can actually see the reduction in edema in the peri-wound skin area. So we were very happy with the outcome. Patient was ecstatic because she was thinking she may have to go back to acute care to get amputation done. So I keep telling her that, well, stop the worry, because we can help, and there's definitely a lot of treatment that we can institute to save your leg. So this is a very successful story, and in the next slide, and I'll pass it back to Dr. Dowsett to talk about negative pressure wound therapy.
Thank you very much, Dr. Wu, and I'd like to congratulate you and your team for the excellent outcome for that patient. And I guess really the lesson for us all is that patients should receive that excellent standard of care, and that it shouldn't just be specialist centres that provide it. All patients should have access to that great standard of care. And I really think what you've demonstrated very nicely, that negative pressure wound therapy offers a solution for these hard to heal wounds. So negative pressure wound therapy is by definition the controlled application of subatmospheric pressure to the local wound environment using a sealed wound dressing which is connected to a vacuum pump. It can be used for traumatic wounds, and that was a very good illustration of that lady knocking her leg, but you can use it in a wide variety of wounds, subacute and dehisced wounds, ulcers, partial thickness burns, acute wounds, used a lot in closed surgical incisions in high-risk patients to prevent wound dehiscence. Great illustrations of where it's used in flaps and grafts to aid healing, and also in these hard to heal wounds that we're talking about here today. And of course, there are traditional negative pressure wound therapy systems and single-use negative pressure wound therapies, which Dr. Wu has just shown us today. So think about the mode of action of negative pressure wound therapy. It protects the wound from external contamination. It removes wound fluid and desiccated tissue. It reduces edema, in turn increases blood flow and promotes tissue formation. And I'd like to share with you now my own study that I've co-authored here using single negative pressure wound therapy in hard to heal wounds. So this was a multi-center study across 10 sites, the UK, Denmark, Sweden, and of course you in Canada. And I'd like to shout out and thanks to the people from Canada who took part in this study so that we can advance our knowledge and our treatment pathways for patients. So what we did was we worked to develop and implement a pathway for using single-use negative pressure wound therapy to kickstart hard to heal wounds. And as part of the study, we evaluated the impact on clinical outcomes and on cost. In this study, we had different types of wounds. So we had venous leg ulcers, diabetic foot ulcers, pressure injuries, dehisced surgical wounds, traumatic wounds, and 4 other types of leg ulcers included. And you can see that the wound duration varied. Some patients, 15 patients, had had their wound for greater than a year, 17 patients less than 3 months. So the mean duration was 1.1 years, and the median was 0.4. I guess the whole driving force behind developing this pathway was that we had questions that we hadn't answers to. And the questions were, when should we start negative pressure wound therapy? How long should we continue it for? What are the most appropriate patients to use it on? And, you know, I think the professional curiosity is often the driving force for us working collaboratively with our peers, our colleagues, and our partners in industry to do what I would call responsible responsible wound care so that we use the appropriate resource on the patient who's likely to have the best outcome. So we had an entry criteria for who we would use it on: wounds greater than 6 weeks duration, where the wound hadn't reduced in size, less than 10% over the previous 4 weeks. Patients were patients who hadn't received negative pressure wound therapy in the 6 weeks leading up to entry to the study. We had excluded infection or treated infection if it was present. If the patient had a lower limb wound, we had done a leg ulcer assessment, including ABPI, and we already had those patients in compression therapy. So with that in mind, we did our assessment and we entered the patient into the study, and then we had decision points. So at 2 weeks, critical to decide, is this treatment working for my patient? So we remeasured the wound and we checked on exudate levels, granulation tissue, pain levels, and then we made a decision as to whether the patient was a good responder, a moderate responder, or not responding to treatment. And if I go into a little bit more detail in the next slide, what that means. So a moderate responder was where we saw a wound area reduction between 10 and 40% per week. So if there were a moderate responder, then we would use our clinical judgment as to whether we continued with PICO. If there were good responders, so we saw a wound reduction area of greater than 40% per week, then we knew that that chronic wound had kick-started into wound healing. And then, of course, if the patient isn't responding, so we had no reduction or less than 5% at week 2, or 10% at week 4, we were seeing no reduction in wound size, but we were also seeing nothing happening in the wound bed, no granulation tissue, or no change, then those patients weren't responding to treatment. And of course, we refer those patients on for more advanced specialist intervention. So what did we find in our study? Well, what you can see here is using single negative pressure wound therapy, PICO significantly improved the healing trajectory by 11.7%. So while applying the PICO, so that was a 13.4% greater reduction than what we were seeing leading up to that PICO application phase. And what we saw was, after that 2 weeks phase or treatment with single-use negative pressure wound therapy, the wound continued on that healing trajectory. So after application, we could see a 9.6 greater weekly reduction compared to baseline. And it's worth reminding ourselves that these were stalled wounds. They weren't just chronic wounds, they were stalled. And in fact, some of them were increasing in size. So if we compared in the study the wounds that had single-use negative pressure wound therapy compared to standard dressings, what we saw was a 61.5% of wounds were either healed or were on a trajectory to healing in 12 weeks. We saw 21% reduction in wound size each week. And what we observed was the wounds that were treated with PICO went on to heal 10 weeks earlier than predicted with standard therapy. I guess a key message here and a key learning for us from our study was that the earlier we intervened, the greater the success. So we saw 94% improvement in wounds that were less than 3 months duration. And the longer the patient had the wound, the slower the response. So the patients that had those wounds up to 6 months went on to healing 71% and 94%. So I think a key message is early identification of those hard to heal wounds and instigation of treatment. So if we look at the study results overall, we saw, as stated, a 21% significant reduction in wound size. We saw that wound healing, 61.5% of wounds healed, and the greater healing rates were in those patients who had them less than 3 months. But what we also saw that costs went down. So we saved 33% on our costs. And I guess for us, that's 50,000 Great British pounds in Canadian dollars, that's 77,000 Canadian dollars, I think, but Dr. Wu will be able to tell me whether my costs are right. And then, of course, one of the things that you said was your challenge was the time looking after these patients. And in this study, we actually released time to care. So 142 days based on that healing trajectory. So our healthcare practitioners were able to free up time to do other interventions. And then what does that mean to the patient? Because these studies have to go back to what this means in terms of the impact to our patients and the human suffering associated with chronic wounds. And you can clearly see here that patients with diabetic foot ulcers and leg ulcers, these were patients in the study. So for the diabetic foot ulcer patient, I think we're talking about saving limbs and saving lives. For venous leg ulcer patients, it's getting them healed within that 12 weeks. I think it's worth mentioning that other people have been inspired by our work and they have replicated it, and we have work here from Pat McCluskey and colleagues in Ireland where they replicated the study. They took the PICO pathway and they implemented it in their areas, and what they saw was quite similar to us. They had an 84.6% healing rate for those wounds that were less than 3 months duration, up to 25% cost savings with 59% reduction for the resource and effort it took to heal these patients, and a reduction in the dressing change frequency. I guess one of the questions that people often ask is, would I use traditional use negative pressure wound therapy for these patients, or should I use single use negative pressure wound therapy? And I'd like to highlight this study from Professor Kistner and his colleagues, which was an RCT looking at the efficacy of single use negative pressure wound therapy compared to traditional negative pressure wound therapy systems in chronic ulcers of the lower extremities. And what they found in this study was that there was a 39.1% greater reduction in wound area in those patients treated with single-use negative pressure wound therapy. There was a 32.5% greater reduction in the wound depth, wound volume 91% greater improvement, and 50% greater healing, wound closure in patients in single-use negative pressure wound therapy versus traditional systems. So, you know, the knowledge is advancing all the time, and we're seeing the higher level studies to support single-use negative pressure wound therapy as part of our pathway of care for these hard-to-heal wounds. I've used negative pressure wound therapy for many years, and it's been very exciting to see the advances in technology and the developments, which I think are much more user-friendly for our patients. We've gone from very heavy systems that made patients housebound for their treatment to these now very discreet and user-friendly systems. And PICO 14 is a very welcome addition to single negative wound therapy, which is designed to treat hard-to-heal wounds. We have 14 days of therapy for our patient, and we can now treat wounds that are deeper than 2 centimeters. And of course, we can use fillers with the PICO 14 as well. And if I translate that into what it means for patients, again, this is, so we did some evaluations recently on the PICO 14 system. This is a 44-year-old lady who presented in our clinic. She had diabetes, she'd had a previous myocardial infarction, and she had incision and drainage of an abscess on her back. There was no evidence of clinical infection. On referral, the wound was 8 centimeters by 2 and 0.5 deep, and she was having traditional negative pressure wound therapy. She carried her device into clinic. It was coming up to Christmas, and she was wanting to get this sorted out and get on with her life, and she was coming twice a week. We applied PICO 14 to the patient's wound. She was very excited that she was walking out with a discrete device. Week 1, the wound was 5 centimeters by 1 centimeters and superficial. By week 2, it had reduced further to 4.5 centimeters, and we healed her in 4 weeks with PICO 14. And of course, we were able to reduce the number of dressing changes, we were able to reduce the cost, and her satisfaction levels were reported as 10, which is on the scale of 1 to 10. So a very satisfied patient with a healed wound. Another patient who we evaluated it on, this is a 36-year-old lady. She had a BMI of 40. She suffered from hypertension, hyperlipidemia. She had a hernia repair and developed a post-operative wound infection resulting in a surgical dehiscence. The wound was static. It was 4 centimeters by 3 centimeters deep. There was a lot of exudate coming from the wound. And we applied PICO 14 with filler, and we were able to reduce the dressing change down for this lady, and we were able to take her on to wound healing. So on evaluation, in terms of progress, in week 1, the wound was 2 centimeters by 0.5, and it was gone to 0.5 deep. So the depth of the wound reduced significantly to the point where we obviously didn't need a filler here. And we went on to heal this lady in 3 weeks. And again, for her, very excited to have such an easy to use, discreet treatment and her wound healed. So I guess really in summing up this session, in conclusion, hard to heal wounds are challenging. You tell us they're challenging. We've shown you the challenge for the patient. We've talked about the challenge for us as clinicians, and we talked about the challenge in terms of the cost. We need to identify these patients early, who's going to be hard to heal, through accurate and detailed patient assessment and wound assessment. And then we need to implement evidence-based treatment pathways so that we improve patient outcomes. So I'd like to say thank you very much for listening. It's been great to collaborate with Dr. Wu, and I'd like to thank our sponsor, Smith & Nephew, for giving us the opportunity to join Wounds Canada. Thank you all at Wounds Canada, and thank you 334 participants for joining us. And we will now go over, I'll hand back to Ashley Hudson, who will take us through the question and answer. Thank you.
Wow. First, I just want to thank both Dr. Dowsett and Dr. Wu for, sharing all of the best practice and information that you just shared with us, and for joining us to really relate best practices globally. So before we go into the Q&A, I see there's a lot of questions and great comments about today's presentation. I'm going to do my best to collate, but if we do happen to miss your question, please be sure to reach out and visit our booth. Upon ending the session, there will also be an evaluation link that will appear in the chat box. So please click on the link or copy and paste the link into your browser and take the time to complete the session evaluation. Your feedback is very valuable to us. So I'll start here with the first question, and this is directed both at Dr. Dowsett and Dr. Wu. Why 2 weeks for advanced therapies such as negative pressure wound therapy, or you also mentioned the 2-week challenge with antimicrobials?
Well, I guess I could start with the negative pressure wound therapy. The evidence suggests that the 2 weeks is the right amount of time to get hard to heal wounds to kickstart. And that was borne out in our study, because the question we asked was, how long should we keep PICO in situ? And what we found from the study was that that 2 weeks was the time that it took to get the therapy to kickstart the wound to healing. And I think, we should be evaluating the patient and the wound at every dressing change. And we should be determining what the response is in terms of healing, because we have to use products appropriately for the patient in terms of getting the right outcome and using the resource effectively.
And from the antimicrobial side, in fact, there are a couple of international consensus documents promoting the same idea that we should be using the 2-week challenge idea. So instead of changing antimicrobial dressings every day or every few days, which is not very cost effective and sometimes counterproductive, to observe the outcome that you want to achieve, a 2-week duration of time is a good way to assess the outcome and the effectiveness of the treatment.
Perfect. Thank you both. Here's another question leading into talking about antimicrobials. Is iodosorb effective against biofilm without sharp debridement?
Well, I'll start this time, Dr. Dowsett. I think the iodosorb could potentially, I think you're talking about iodosorb, right, Ashley?
Yes.
Definitely, I think it may help actually deslough the wound bed and facilitate better wound healing, and at the same time manage the biofilm on the wound bed as well. So it serves many different functions. When you look at the literature, comparing different types of autolytic debridement agents, even though there's no enzymatic property in iodosorb, but in comparison to hydrogel, iodosorb is superior to promote autolytic debridement. So I think it's a great idea when you have sloughy wounds to use iodosorb as a desloughing agent.
Excellent. And if I can just add to that, there is actually also a RCT that was published back in 2017 by Dr. Matthew Malone that was actually in patients with diabetic foot ulcers, where they did punch biopsy to confirm that there was a biofilm, applied iodosorb, and just 2 weeks of iodosorb, they re-punch biopsied, and the biofilm had been in fact eradicated without sharp debridement. Anything else to add, Dr. Dowsett, about iodosorb? And
yeah, I was going. Thank you. Actually, I was going to mention the Matt Malone study because I think it's very interesting. Because when we look at the advice around the management of biofilms, we talk about multi-strategies, including sharp debridement. But of course, many people caring for patients with chronic wounds don't have the skill of sharp debridement, and patients have to get referred to specialist centres to have that treatment. So we have to think about what debridement methods can generalist practitioners use, and knowing the results of that study, that the cadexamer iodine debrided the wound and removed that biofilm without the necessity for sharp debridement, is a very interesting result.
No, that's fantastic. And that kind of leads into another question about the use of negative pressure wound therapy. If you suspect biofilm, would you start with, a biofilm effective product like iodosorb, or would you, start with the negative pressure wound therapy?
Okay, shall I take this one, Dr. Wu?
Please do.
Well, I guess, if we're going to use advanced therapies on patients, we need to make sure we prepare the wound bed for them to be most effective. So I think wound bed preparation is important. Wound bed preparation is important for healing, regardless of whether you're using advanced therapies. So that cleansing, debridement, treating infection, and all the other components of wound bed preparation. So I would always prepare the wound bed before I applied single-use negative pressure wound therapy.
Yeah, I think the same thing. I think we need to prepare the wound bed. Now, mind you, though, I mean, off-label, because Smith and Nephew, they don't like us to talk about this. In my clinical experiences, I've used iodosorb powder and sprinkle on the wound bed first and apply PICO dressing on top. If you're concerned about biofilm problem, the concern is you don't want to put too much powder on the wound bed, because the concern is it may clog up the sucking mechanism. So you have to use it judiciously. But I've used a number of cases applying the iodosorb powder first and then the PICO dressing on top. And actually, I find it enhance the exudate management and also improve the quality of tissue, because we're addressing the infection problem at the same time.
Very interesting. That actually leads into another conversation, a question about can you apply single-use negative pressure or PICO if you are concerned about wound infection? Would that be perhaps where you could use antimicrobials dressings? I believe actually one of your case studies that you've shared previously, Dr. Wu, was actually showing the use of Acticoat Flex, the nanocrystalline silver dressing, in combination with PICO.
Yeah, I think, and Dr. Dowsett can talk more about that as well. I mean, she got a wealth of experiences in using this combination. Yeah, I think because the Acticoat Flex material for people not familiar with, is a very thin layer of polyester, lots of fenestration and holes on the material that make it an ideal type of material that you can place underneath PICO dressing, allowing the suction to transmit from the PICO material to the wound bed. At the same time, the actical flax material release the silver into the wound bed to kill bacteria. So you can actually achieve a number of things at the same time. Not often that I would suggest piling things up in the wound because it's just wasting resources. But in this case, you can achieve more by doing the combination.
Excellent. And anything else to add, Dr. Dowsett?
Yeah, no, I absolutely agree with Dr. Wu. It's something we do. I think Dr. Wu highlighted the infection management pathway. And I think when we're talking about infection, it's important to identify what type of infection are we talking about. So if patients have got systemic infection, then obviously we need to treat that systemic infection and make sure our patients don't go on to develop septicemia. But when you've got that local infection in the wound, which does respond quite well, that planktonic bacteria in the wound that does respond well to actical silver dressings, then you can use that combination. If you're dealing with a biofilm, then obviously you want to disrupt that biofilm before you put on negative pressure wound therapy. So I think, Dr. Wu talked about the dexmedetomidine combined. That's an interesting proposition, Dr. Wu.
And a clinical decision, not recommended by Smith and Nephew, just throwing that out there. But definitely there's lots of clinicians across Canada that are trying that combination. There's a couple of questions just about, when should we actually start therapy with PICO? Is it better for the wound to stall before applying PICO? Or if I see signs that a patient is at higher risk due to their comorbidities or other factors, would then I apply PICO and intervene earlier?
Okay, that's a good question. And I think what I would always say is, we need to be really good at doing that initial assessment, picking up those patients that will be hard to heal. And if I use the patients who are high risk of surgical wound dehiscence, then we've got meta-analysis, randomized controlled trials that show that putting on that PICO dressing prophylactically will stop that patient getting a wound dehiscence. So it's about using your clinical judgment combined with the evidence. If we look at these more chronic wounds, such as our lower limb wounds that are much of the work that I am involved in, then again, I think we need to be good at doing that reassessment. So I have patients who have underlying comorbidities who come in with a venous leg ulcer, but I can manage to heal them in compression. But some of those patients I won't heal in compression alone. So it's about, at that 4-week point, is compression advancing that venous leg ulcer? And if it's not, then we would start negative pressure wound therapy as an adjunct to compression therapy. So I think for some patients, yes, you would go ahead doing it prophylactically, but I think you would want to know, is my treatment working? And is my treatment evidence-based? So am I compressing that leg correctly? Have I got the right amount of compression? And if you've done all of the standard care and you're giving the right care and you're not getting that wound to reduce in size, then I would start treatment with negative pressure wound therapy.
I guess the famous answer is all depends, right? Depends on the type of wound, depends on the type of patient. Very, very well put, Dr. Dowsett. The other thing I want to add is when you think about what Dr. Schultz from the United States have talked about, the step up, step down paradigm, perhaps we need to rethink the way we approach chronic wounds. Perhaps the time, the E should not be always the last factor to consider. Yes, you do want to make sure that you address infection properly first, but we might want to put a lot of aggressive interventions at the very beginning to facilitate healing, including negative pressure wound therapy. So I think we have to be more vigilant and be more be more mindful of the different interventions that we can help with the healing process.
No, that's great clarification. Thank you so much. And that actually brings up there's a question, related to compression therapy, and I note that both of you have utilized PICO under compression therapy. Any comments about how you found that application, or how the patients found the application of the PICO device under compression therapy?
I guess if I might start, because I'm in leg ulcer clinics most weeks, I think, there was huge challenges for us as clinicians using traditional negative pressure wound therapy in patients who walked into leg ulcer clinic. Because not only did they walk out with compression bandages, they walked out with a device that they had to carry as well. So when single-use negative pressure wound therapy was made available to us, we were very excited and our patients were very excited. So I think it's revolutionized our care of those patients when we use it as an adjunct to compression therapy. It weaves very nicely through the compression layers, and the patients can just tuck it in at the top of the bandage and put the trousers down, and they don't know they've got it there. So I think I've great patient stories and experience of using it in leg ulcer patients as an adjunct to compression therapy.
Absolutely. I think I echo what Dr. Dowsett is talking about. And I saw a few questions about my case, whether compression therapy was used. And definitely we used different types of compression therapy because of the lymphedema and swelling problem. But we used different types of compression as we move across the different phases of wound healing. At the beginning, because there was a lot of exudation, we were using Comprolan, which is reusable. We can rewrap it on a day-to-day basis to facilitate dressing change. And then gradually we move into a 2-layer Coban material, and that will allow us to reduce the frequency of dressing change. So it really depends on how the wound is responding, the amount of exudate. We try to be very cost conscious about what we use because obviously it's not very cost effective and cost saving to change those 2-layer bandages every day. They could be quite costly.
No, that's great. And what type of compression therapy do you use in your practice, Dr. Dowsett, with the PICO?
With PICO, you can use, we're heading, because of the COVID-19 pandemic, we're using a lot of wraps right now, and you can use wraps. You can use the PICO 14 with the wraps as well as with compression bandages. So I think it can be used with any type of compression.
Yes, indeed it can. Now, I've seen a lot of comments coming through asking for information about your webinar, the infection management pathway. So please do pop on over to our booth and we'll provide you with the link to register to the upcoming infection management pathway webinar. And both Dr. Wu and Dr. Dowsett will be going into a full detail of how to utilize the infection management pathway. There's also questions about what type of wound fillers can you utilize with PICO 7 and 14 for deeper wounds when a filler is required.
So for the patient that I presented, we used a foam filler because the wound had regular edges. If you've got a wound where you've got irregular topography or you've got undermining, then you might be better using an antimicrobial gauze filler.
And I agree, anything sort of porous and anything that allows the negative pressure to be transmitted from the PICO dressing to the wound bed could potentially be used. And similar to Dr. Dowsett's experiences, we have used gauze-like material with AMD. We have used definitely the flax dressing, and they come in ribbon. And they also come in, we can also cut the sheet into a spiral material, allow us to pack into the wound. And we also have used foam material like the Gentle Violet Methylene Blue into the deep tunnel. Anything that sort of have holes on it will allow the negative pressure to be transmitted.
Excellent. No, thank you. Thank you for clarifying and just raising that good point of the need for the wound fillers to be able to transmit the negative pressure wound therapy to the base of the wound, but also for that fluid to pass through the filler to the dressing itself. There's a lot of questions that have been coming in regarding sizes for PICO. There is actually a total of 10 different sizes, so very flexible. Again, pop on over to our booth and we can show you all of the different sizes and functionality. Also, there's a question here asking about the contraindications for using a PICO. So the same contraindications, indications for use, and precautions are the same with the PICO device as traditional negative pressure wound therapy. The one addition with PICO is that it does have the indication to be used prophylactically on closed surgical incisions to prevent surgical site complications.
Ashley, I saw a question about what fillers that you should not be used under the PICO. I think that's a great one because we talk about what we should be using. Just want to highlight material that sort of has a very dense structure. For example, hydrofiber. It would not allow the negative pressure to get through. Even though it's a very absorbent material, and even sometimes some of the calcium alginate, if you pack it, depends how you pack it, and it could be so dense that it doesn't allow the negative pressure to get through. So be careful with that.
No, that is a fantastic point. So thanks again for clarifying that, Dr. Wu. It is our time to wrap up. So once again, I thank both of you for your time. I thank all of you for joining us today on today's education session. And I hope that you pop on over to our booth. Please fill out the survey. And I hope that you all have a fantastic weekend celebrating Wound Canada 25th conference. Thank you so much.
Thank you.
Thanks, Dr. Wu. Thanks, Dr. Dowsett. Thank you, Ashley.
Thank you.